Another intranatal complication is placenta accreta. And to report on this serious pregnancy condition, I am Ms. Tabuco Nicole Uriel, and together with me is Ms. Demapias Rajan Catherine to broaden your knowledge about this complication. Let us first start in defining this pregnancy condition. Normally, the placenta detaches from the uterine wall after childbirth, but with placenta accreta, part or all of the placenta remains attached, which can potentiate the risk of severe blood loss after delivery. So what is the root of this complication? It is caused by partial or complete absence of the decidoa with adherence of the placenta directly to the myometrium. It is thought to be related to abnormalities in the lining of the uterus, typically because there is a scarring after a C-section or other uterine surgery. There are many factors that can heighten the risk of placenta accreta. It includes previous uterine surgery. As the number of C-sections or other uterine surgeries increases, the risk for placenta accreta also increases. Placenta position: if the placenta partially or totally covers the cervix or sits in the lower portion of the uterus, then the patient is at risk for placenta accreta. Placenta accreta is more common in women older than 35 years old, and the risk of placenta accreta increases as your number of pregnancies increases. There are three types of this complication. It includes placenta accreta, placenta increta, and placenta percreta. In placenta accreta, the placenta is firmly attached to the wall of the uterus. It does not pass through the wall of the uterus or impact the muscles of the uterus. And among the three, this is the most common type of the condition. Placenta increta, the placenta is deeply embedded in the wall of the uterus. And similar with the first type, it still does not pass through the wall, but it is firmly attached to the muscles of the uterus. In the last type, placenta percreta, this happens when the placenta passes through the wall of the uterus. The placenta might grow through the uterus and impact other organs such as the bladder and intestines. And among the three, this is the most severe but the least common among the types. The signs and symptoms for placenta accreta. This complication often causes no signs or symptoms during pregnancy, not until labor and delivery. Although vaginal bleeding during the third trimester might occur, during labor and delivery, massive bleeding is observed. In cases when deciduous basalis is absent, the placenta will not loosen and fails to be delivered. Under the nursing management, obtain a detailed obstetric history for baseline data to promote optimum level of care. Identify placenta accreta in the client. Be aware of the client's risk status. Assist with modalities implemented. Assist with rapid treatment and intervention. Provide physical and emotional support to promote comfort and assurance. Provide client and family education to promote good health education. Administer the necessary medication as prescribed by the physician. For clients taking methotrexate, instruct the woman to increase fluid intake to at least 2 liters each day as uric acid formation is increased with the drug use. Moving on to the medical management for this condition, conservative treatment is done if the woman wants to maintain her fertility under the condition that no active bleeding is present. The technique for this is the placenta is left in the uterus and the cord is ligated, and the closure of uterus is performed.
Good day, everyone. I am Ms. Demapias, and I will continue the rest of the subtopics for placenta accreta. So we have the pharmacologic management. We have the methotrexate, which is an anti-neoplastic agent which acts to prevent or inhibit the development of a neoplasm. Hence, it is usually given to the woman to destroy the still attached placenta. So women taking methotrexate should be monitored for white blood cells and platelet count, since thrombocytopenia and leukopenia may occur 7 to 14 days after the initiation of the treatment. Also the blood urea nitrogen, the creatinine and urine pH, and the pH should be above 7.0. Presence of dry and non-productive cough may be an early sign of pulmonary toxicity. Symptoms of gout must be assessed frequently, like the increased uric acid, joint pain, edema. And take note that methotrexate causes increased serum uric acid, and we have the allopurinol that could be given to decrease uric acid levels. Next, we have the surgical management. In the case of extensive placenta accreta, a C-section followed by the surgical removal of the uterus, which is also called the hysterectomy, might be necessary. Or you can call this procedure as cesarean hysterectomy. So this helps prevent the potentially life-threatening blood loss that can occur if there's an attempt to separate the placenta. So we have here relevant pictures and we placed links for the videos. For the left side, that's the normal position of the placenta in the uterus during pregnancy. Then at the right side, that's the picture of a placenta accreta. This is also the picture shown on the screen are the different types of accreta, placenta accreta. Okay, so we have here another picture for the types. We have the normal, the accreta, the increta, and then the percreta. So these are the links. You could watch this if you have time. Next, we have the nursing care plan. For the needs, problems, or cues, we have physiologic overload. The problem is risk for bleeding. Objective cues, impaired contraction of uterus, shortness of breath or dyspnea, longer capillary refill, and for the subjective cues, as verbalized by the client, wala ko'y kusog, unya, maglipong-lipong sad ko, kapoy kaayo akong pamati. For the nursing diagnosis, risk for bleeding related to deep tissue attachment of the placenta. Scientific basis. Placenta accreta is related to the abnormalities in the lining of the uterus. It is a serious pregnancy condition that occurs when the placenta grows too deeply into the uterine wall. Vaginal bleeding during the third trimester might occur. If not detected, this can cause severe blood loss or hemorrhage after delivery. The bleeding can cause a life-threatening condition that prevents your blood from clotting normally, disseminated intravascular coagulopathy, as well as lung failure, adult respiratory distress syndrome, and kidney failure. For the objectives of care, general objectives. After 1 week of student nurse-patient interaction, the patient will be able to manifest the compliance of safety precautions and preventive measures to reduce the risk of bleeding. We have specific objectives. After 8 hours of nurse-client interaction, the client will be able to identify individual risks, maintain heart rate, blood pressure, hematocrit, and hemoglobin levels within normal ranges, and engage in appropriate behaviors or lifestyle changes to prevent bleeding. We have the nursing interventions. I divided it into 3: independent, dependent, and collaborative. Measures to reduce the risk of bleeding. So determine the patient's health history for signs that can be associated with a risk of bleeding and monitor changes in vital signs. Its rationale would be early identification of possible risks for bleeding provides a foundation for implementing appropriate preventive measures. Next, monitor hematocrit and hemoglobin. Rationale would be when bleeding is not visible, decreased hemoglobin and hematocrit levels may be an early indicator of bleeding. Next, maintain bed rest. Provide undisturbed rest periods and prevent vomiting and straining at stool. Activity and vomiting increase intra-abdominal pressure and can predispose to further bleeding. So I will just state in advance the evaluation. After a week of student nurse patient interaction, the client was able to comply with safety precautions and preventive measures to reduce the risk of bleeding. Next, we have another independent nursing intervention. Instruct client in relaxation methods such as meditation, guided imagery, and deep breathing techniques. The rationale would be it decreases stimuli, refocuses attention, hence lowering the level of discomfort. Next, we have recommend avoidance of aspirin containing products. The rationale would be it prolongs coagulation, potentiating risk of hemorrhage. Next, lastly, for the independent, encourage clients to follow a healthy lifestyle and avoid activities that can affect their body. The rationale to boost clients' energy towards her pregnancy and refrain from detrimental scenes that may affect the fetal movement. Next, we have dependent nursing intervention. Administer blood products as indicated. Rationale of this intervention would be transfusions may be required in the event of persistent or massive spontaneous bleeding. Next, assist or have a routine ultrasound checkup with the client's doctor. So the rationale for this one is that placenta accreta is detected during a routine ultrasound. Lastly, we have the collaborative nursing intervention. Provide emotional support and physiologic compensatory responses of anxiety and fear to the patient. This is important because this helps in patient's assurance and calming.
Greetings. I am Ms. Nangakit Zia, and I'll be reporting battledore placenta. First, we have the definition or description of the complication. So, what is battledore placenta? Battledore placenta is a condition, also known as marginal cord insertion, refers to the cord that is inserted marginally rather than centrally. So called because of the fancied resemblance to the racket used in badminton. The shortest distance between the cord insertion and placental edge is within 2 centimeters. This is a rare anomaly and it has no known clinical significance. Battledore placenta can be found in association with other conditions such as monochorionic twin pregnancy, intrauterine growth retardation, and preterm birth. The marginal vessels are more likely to undergo twisting, occlusion, or thrombosis. Complications associated with battledore placenta are fetal distress, intrauterine growth restriction, preterm labor, and slightly decreased birth weight. Now we have the etiology and cause. There are no causative factors associated with marginal insertion of the umbilical cord. However, twin and multiple pregnancies are some of the risk for this condition. The umbilical cord attaches to the edge of the placenta instead of the central placental mass. The placenta is thinner in the edges and therefore less able to structurally support the umbilical cord. Risk factors include risk for premature rupture of membrane, spontaneous preterm birth, short cord, stillbirth, intrauterine growth restriction, slightly decreased birth weight, and hemorrhage. Signs and symptoms associated with battledore placenta are excessive bleeding or hemorrhage in the third stage of labor, blood vessel compression, thrombosis, pain of the lower abdomen, decreased blood flow or blood supply in the fetus, inconsistency of fetal heart tone, and the marginal insertion may be observed through an ultrasound scan. Moving on with the nursing, medical, pharmacologic, and surgical management of battledore placenta. First, you have nursing management. Close and careful monitoring during labor to avoid further complications and blood loss. The maternal vital signs are monitored every 15 minutes and blood loss is evaluated. The amount of bleeding is estimated and documented. Fetal heart tones are also monitored to detect fetal distress. Oxygen and equipment should be at hand in the event signs of fetal distress indicates anoxia. Second, we have medical management. Conditions may be diagnosed by a physical examination, evaluation of complete medical history. Replacing blood loss and fluids is important in treating postpartum hemorrhage. Giving quickly IV fluids, blood, and blood products to prevent shock. Oxygen may also help. Third, we have pharmacologic management. Anticoagulation therapy is the treatment for deep vein thrombosis diagnosed during pregnancy. Low molecular weight heparins usually are the first line medications. Anticoagulants therapy may need to be continued into the postpartum period when the risk for deep vein thrombosis or venous thromboembolism increases. The medications most commonly used in the postpartum hemorrhage management are uteronic agents. These medications include oxytocin, misoprostol, methylgonovin maleate, carboprost, thrometamine, and dinoprostone. Lastly, we have the surgical management. Caesarean section may be necessary to avoid some of the complications. Laparotomy. This is a surgery to open the abdomen to find the cause of bleeding. Tying off or sealing blood vessels. This is done using uterine compression sutures, special gels, glue, or coils. The surgery is done during laparotomy. Hysterectomy. This is a surgery to remove the uterus. In most cases, this is the last resort. So these are relevant pictures of placental battledore, also known as marginal cord insertion. So moving on with the nursing care plan. So focusing first on the needs, problems, and cues. The nursing diagnosis is impaired tissue perfusion, which is a physiologic overload. The objective cues are inconsistent fetal heart tone, decreased movement of the fetus in the mother's womb, a fetal heart rate of 160 beats per minute, mother's vital signs of 37.2 Celsius as temperature, 130/80 mmHg as blood pressure, 103 beats per minute as heart rate, and 21 breaths per minute for respiratory rate. The subjective cues are, the client verbalized, "Naglisod ko ginhawa, unya nalipong ko. Kapoy kayo ako paminaw." For the nursing diagnosis, we have impaired tissue perfusion related to decreased blood flow and oxygen supply, as evidenced by inconsistent fetal heart tone and fetal vital signs. For the scientific basis, a marginal cord insertion may cause a decrease in blood flow to the developing fetus. This can result in fetal distress, intrauterine growth retardation, or IUGR, and other congenital abnormalities in the developing fetus. Marginal insertion of the umbilical cord may include excessive hemorrhage during childbirth and decreased blood supply to the fetus, which affect the fetal growth and development of the fetus. Now let's move on to the objectives of care. For general objectives, after 1 week of student nurse and patient interaction, the client will be able to manifest minimized discomfort and good fetal variability for safe labor. For specific objectives, after 8 hours of nursing intervention, the client will be able to manifest consistent fetal heart tone and stable vital signs. Now let's focus on the nursing intervention and the rationale that comes with it. So the first, we need to monitor fetal heart rate. As by monitoring the fetal heart rate, this aids to determine the fetal status. Number 2, place the mother facing turned towards her side, as this procedure relieves pressure on the umbilical cord during contraction and pressure on the uterus on the inferior vena cava. Number 3, administer of oxygen. This is to supply the mother enough oxygen it needs and to be able to breathe properly. Number 4, check for the prolapse of the cord. This is to avoid further complication when the out of the blood flow through the umbilical cord can become blocked or stopped. Number 5, notify healthcare provider. Earlier intervention do not cause fetal heart rate tones to become reassuring. So the first initial interventions are done in order to stabilize the fetus and the mother to avoid further complications. Notifying the attending physician is a must. For the second, option of intervention to be done. Number 6, we have to administer medication as directed to the physician, such as tocolytic medication to reduce the strength or frequency of contraction, as this also improve blood flow and therefore improve the fetal well-being. 7th, we have the emergency cesarean section performed by the physician. If the cervix is not fully dilated or the fetal head is more than 1/5 above the symphysis pubis or the leading bony edge of the head is above zero station, this is to avoid the distress of the fetus to get more serious as well as premature injury and disability.
So good day everyone. Today I will be talking about vasa previa. So let us first define what this disease or complication is. Vasa previa is an incredibly rare but severe complication of pregnancy. In vasa previa, some of the fetal umbilical cord blood vessels run across or very close to the internal opening of the cervix. These vessels are inside the membranes, unprotected by the umbilical cord or the placenta. As such, they are at risk of rupturing when the membranes break. Let us now talk about the etiology or the cause of this condition. Vasa previa can occur in its own or with placental abnormalities, such as a velamentous cord insertion. So in a velamentous cord insertion, vessels from the umbilical cord run through part of the chorionic membrane rather than directly into the placenta. Thus, the blood vessels are not protected by the Wharton jelly within the cord, making fetal hemorrhage more likely to occur when the fetal membranes rupture. So another cause of this condition is a bilobe placenta, where the placenta is in two pieces, and in these cases, the vessels may be unprotected where they cross between the two lobes. So risk factors for this condition includes the following: multiple pregnancies, moms-to-be who are carrying multiples such as twin and triplets, IVF, moms who became pregnant via in vitro fertilization have an increased risk of developing this condition as well. Accessory placental lobes. It is a condition where the placenta does not form properly and has one or more separate accessory parts or lobes apart from the main placental disc. A velamentous cord insertion. This is an abnormality where the umbilical cord, instead of inserting directly into the middle of the placenta, it inserts itself into the fetal membranes and travels through them to reach the placenta. Previous C-sections. Women who have given birth previously by a C-section or have had other uterine surgeries are also at risk of developing vasa previa. Low-lying placenta. If the placenta is low-lying, then it can also lead to vasa previa in pregnant women. So vasa previa has two different types. First, we have the type 1 vasa previa. It occurs when there is a velamentous cord insertion between the umbilical cord and placenta, and fetal blood vessels running freely within the amniotic membranes overlie the cervix or are in close proximity to it. Next is the type 2 vasa previa, which occurs when the placenta is multi-lobed or typically bilobed, and fetal vessels containing the two placental lobes course over or near the cervix. So, what are the signs and symptoms of this condition? Rupture of membrane that results to painless bleeding is one of the major symptoms of vasa previa. Fetal bradycardia is also a sign of vasa previa. It happens when the fetal heart rate becomes abnormally slow if the blood vessels rupture and start bleeding. The diagnosis is often made with transabdominal color, Doppler sonography, demonstrating flow within vessels which are seen overlying the internal cervical os. So for our nursing diagnosis, we have impaired fetal gas exchange related to active blood loss, evidenced by disrupted placental implantation. So how can we manage this condition? For a nursing management, obtain a detailed obstetric history, monitor the mother's vital signs, reposition the patient, monitor amount and type of bleeding, encourage relaxation techniques, monitor uterine contractions to establish the progress of labor of the mother. For our medical management, we have continuous monitoring of the fetus and mother and administration of oxygen to improve circulation. For our pharmacologic management, we have the administration of antenatal corticosteroids, betamethasone and dexamethasone, which are the most widely studied corticosteroids, and they generally have been preferred for antenatal treatment to accelerate fetal organ maturation. For our surgical management, if vasa previa is detected prior to labor, elective cesarean delivery would be the method of choice. Here we have the relevant pictures for vasa previa. Now let us proceed to our nursing care plan on this complication. For our needs or problems or cues, we have the physiologic overload, which is the impaired fetal gas exchange, objective cues, bleeding episodes, vital signs of BP 90 over 60, temperature of 36.9, respiratory rate of 22, and pulse rate of 96. For the subjective cues, we have I was nervous and shocked when I saw I was bleeding. I also feel weak, as verbalized by the mother. For our nursing diagnosis, we have the impaired fetal gas exchange related to altered blood flow, evidenced by disrupted placental implantation. And for our scientific basis, we have adequate blood flow to and from the placenta and in both the maternal and fetal circulation is necessary in order for the baby to receive enough oxygen and for it to be able to expel carbon dioxide and other waste gases. Um, any alteration in placental function can lead to decreases in delivery of oxygen to the baby, a condition known as fetal hypoxia. And then for our objectives of care, we have the general objective. After 12 hours of nursing interventions, the client will be able to verbalize and understand causative factors and appropriate interventions. For our specific objectives, after 8 hours of nurse patient interaction, the patient will be able to identify different risks for the condition, manifest hemodynamic stability, demonstrate use of relaxation skills or diversional activities. For our nursing interventions, we have the independent, assess the client's vital signs after every 15 minutes. This is to have a baseline on the client's condition, encourage client to have enough rest to reduce fatigue and improve strength, monitor the amount and type of bleeding present to gather enough evidence or idea how worse the bleeding is. And for our dependent nursing intervention, we have monitor the fetus through external monitor. This is to assess the fetal condition, make sure that the client adheres to medications as given by the physician, to make sure that the medication will improve or help the client in feeling better. And for our collaborative nursing intervention, we have referral to other healthcare teams to work hand in hand to ensure that thorough treatment has been or will be done.
Good day, everyone. This is Rama, and I'm here to discuss about the two-vessel cord. So now let's talk about the two-vessel cord. So it's an umbilical cord that has two arteries and one vein. However, some babies have just one artery and vein. This condition is known as two-vessel cord diagnosis. And doctors may also call this a single umbilical artery or SUA. So now let's talk about the etiology or cause. The artery doesn't grow properly in the womb. Some women are more likely to have a two-vessel cord than others. The risk factors of a two-vessel cord are the following: being a white person, being older than age of 40, being pregnant with a girl, having history of diabetes or high blood sugar episodes during pregnancy, pregnant with multiple babies like twins or triplets, and taking medication known to affect fetal growth like phenytoin. So the two-vessel cord doesn't have any signs or symptoms before it's diagnosed. For the management, we have nursing management, medical management, and the surgical management. So now let's talking about the nursing management. First, we must inspect if the cord as to how many vessels are present must be made immediately after birth before the cord begins to dry, because drying distorts the appearance of the vessels. Next, we must document the number of vessels conscientiously, because an infant with only two vessels needs to be observed carefully with other anomalies during the newborn period. For the medical management, we have ultrasound. So, if your doctor or ultrasound technician detects a two vessel cord by lower definition ultrasound, they may suggest a higher resolution scan to more closely examine your baby's anatomy. Sometimes your doctor may also recommend amniocentesis. They can help to determine the lung maturity and other development related conditions. The other tests or reviews a doctor may recommend include personal medical history, family medical history, fetal echocardiogram to viewing the chambers and workings of the fetal heart, and screening for genetic abnormalities and pregnancy, like an aneuploidy screening. And lastly, for the surgical management, we have cesarean section. Isolated single umbilical artery is associated with increased risk for cesarean section due to non-reassuring fetal heart rate, prolonged neonatal admission, low Apgar score, and umbilical artery pH which is less than 7.2. So here's the relevant pictures of the two vessel cord. As you can see, these pictures has two arteries and one vein. For the umbilical vein, it carries oxygen-rich blood to the baby, and the umbilical arteries carries oxygen-poor blood away from the fetus and to the placenta. The placenta returns the waste to the mother's blood, and the kidney eliminates them. Babies with a two vessel cord may also be at higher risk for not growing properly. This could include preterm delivery, slower than normal fetal growth, or stillbirth. So now let's proceed to the nursing care plan in this complication. For the needs or problem cues, we have physiologic deficit, the risk for fetal injury, and the risk factors are the following: problems with the uterus and chromosomal abnormalities. For the nursing diagnosis, it is risk for fetal injury related to having only one artery in the umbilical cord. For the scientific basis, fetuses and neonates with single umbilical artery and isolated single umbilical artery are at increased risk for adverse outcomes. Identification of a single umbilical artery is important for prenatal diagnosis of congenital anomalies and aneuploidy. For the objectives of care, we have general objective and specific objective. For the general objective, after 1 week of holistic nursing care, the client will participate in interventions and or measures to reduce the risk for fetal injury. As for specific objective, after 8 hours of nursing intervention and interaction, the client will be able to: number 1, maintain stable vital signs; number 2, verbalize understanding the current situation and possible outcomes. So now let's talk about the nursing intervention for the nursing care plan. Number 1, we need to assess the vital signs of both the mother and the fetus. For the rationale, we need to ensure their stability and safety. Next, administer a magnesium sulfate as indicated by the physician for the rationale to prevent these seizures due to stop or slow preterm labor. Next, teach client to watch for and report nausea, vomiting and diarrhea, urinary tract infection, vaginal spotting, bloody show, discharge of mucus plug. For the rationale, we early detection of impending premature labor enables interventions to ensure successful delivery and decrease the risk of complication. And lastly, we need to maintain the approach to the fetal outcome and for the rationale to support the mother child bearing.
Good day, I am Ronald Go and I'm going to report about unusual cord length. For the definition and description of the disease or complication. Unusual cord length. Cord length longer or shorter than the average umbilical cord. 55 centimeters long with a diameter of 1 to 2 centimeters and 11 helices. For etiology and cause. Causes of differences in cord length are unknown. However, the length of the cord is thought to reflect movement of the fetus in utero. Specific cell type differences and protein expression patterns of several genes related to cell proliferation may also have a contributory role in cord length anomalies. Types of abnormal cords. Short cords are associated with fetal movement disorders and intrauterine constraint, as well as placental abruption, cord rupture, and emergent cesarean deliveries for non-reassuring fetal heart rate. Although short cords have been blamed for the inability of some fetuses to deliver vaginally, available data suggests that vaginal delivery can take place with cords as short as 13 centimeters, which is much shorter than the normal range. It can result in premature separation of the placenta or an abnormal fetal life. For long cords are associated with fetal entanglement through knots and thrombi. May also be easily compromised because of its tendency to twist or knot. For signs and symptoms, short cords, decreased blood flow to the fetus resulting in fetal distress, non-reassuring fetal heart rates, non-reassuring fetal heart rate associated with cord compression, fetal movement disorders such as fetal inactivity and placental abruption, oligohydramnios, rupture of the cord, neurological disabilities, delivery complications and operative vaginal delivery, and intrauterine growth restriction. For long cords, obstruction of blood flow causing reduced blood flow to the developing fetus, compression of umbilical cord. There could be an associated polyhydramnios, increased fluid in gestational sac, wrapping of the long umbilical cord around the fetal parts. For management, nursing management, turn the client on her left side to increase placental perfusion. Administer oxygen 8 to 10 liters per minute as ordered by the physician to increase fetal oxygenation. Increasing the IV fluid rate as ordered by the physician to improve intravascular volume. Monitor maternal and fetal vital signs to detect any changes in the fetal heart rate. Providing reassurance that interventions are to effect pattern change to help relieve patients' anxiety and stress levels. For medical pharmacologic management, a careful and periodic monitoring of the pregnancy is necessary, since the presence of long umbilical cord is considered to be high-risk pregnancy. Surgical management. If a diagnosis of long umbilical cord is established prenatally, then an elective cesarean section may be undertaken. If the diagnosis is made during childbirth, then an emergency C-section may be helpful. Alternatively, an operative vaginal delivery may have to be performed. If the condition is diagnosed during childbirth, this procedure may be performed using techniques such as forceps delivery and delivery using vacuum extractor. An operative vaginal delivery may have to be performed if the condition is diagnosed during childbirth. It can help in expediting the process of childbirth. The operative vaginal delivery may be performed using techniques such as forceps delivery and delivery using vacuum extractor. If a prenatal diagnosis of the condition has been established, then an elective cesarean section delivery may be considered. A careful and periodic monitoring of the pregnancy is necessary, since the presence of short umbilical cord is considered to be high-risk pregnancy. In case of fetal distress, an immediate delivery of the baby should be considered. For nursing care plan, for needs, problems, and cues, physiologic deficit, risk for injury. For objective cues, mark tachycardia with 171 beats per minute, moderate variable decelerations, and uterine tachysystole, 7 uterine contractions in 10-minute period. For subjective cues, sige contract akong Tiyan murag dili siya usually naitabo nako as verbalized by patient. For nursing diagnosis, risk for injury related to short cord length. For scientific basis, partial occlusion of the umbilical vein by cord compression or stretching will decrease blood return to hypotension, stimulate the sympathetic system, leading to compensatory tachycardia. For objectives of care, general objectives. After 1 week of student-nurse-client interaction, the patient will be able to reduce risk of fetal injury. And for specific objectives, after 8 hours of holistic nursing care, the client will be able to maintain heart rate within normal limits as evidenced by heart rate of 120 to 160 beats per minute. Reduce risk of fetal injury, and fetus will be free from preventable trauma or any complications. And for nursing interventions, measures to prevent variable decelerations, turn the client on her left side to increase placental perfusion. Administer oxygen 8 to 10 liters per minute as ordered by the physician to increase fetal oxygenation. Increasing the IV fluid rate as ordered by the physician to improve intravascular volume. And monitor maternal and fetal vital signs to detect any changes in the fetal heart rate. And providing reassurance that interventions are to effect pattern change to help relieve patients' anxiety and stress levels.